this in a session. I'm not going to post it anyway. Huh?
All right, sure.
It's a live, so I think it's too difficult for anyone to view.
Did you move your screen, ma'am? Because your voice is again gone back to.
Yeah. Okay. Yes. How's that?
Yeah, I think
okay.
that's better.
So you do yours the problem.
All right.
Okay. Thank you.
You
can mute yourself. Just be around and mute it.
Sure.
Okay. Thanks. Okay, guys. Good evening. We'll get started with the first angio. Okay, so let's see here. Easy. I'm starting with the easy one. Diagnosis. What is the diagnosis here? Okay. PDA. Do you think the PA pressure is that's right? So do you think the PDA, the pulmonary artery pressure is low or high? Pressure low or pressure high? Pressure is low, right? So everybody can see there's a restriction. So it's going right where it enters the pulmonary artery. And if you see even on your echo, that the exact narrowest point of your PDA is always where it enters the pulmonary artery. And so what a lot of people do is they actually measure the ampulla. And you can see here, I'm just going to annotate for the first year fellows. So you see this is your ampulla. This point here is the narrowest point of the PDA where it enters into the pulmonary artery. But what a lot of people do on echo is they actually measure the ampulla and they say over 6 mm or 8 mm, which is not where you should be measuring it. So you have to measure it at this point. So if I asked you what was the size of this PDA, you were going to measure right here, right where the narrowest part is. Right? And since that is restricted, this is going to be a likely a normal PA pressure. Okay. Now, when you this kind of a case, what would you like to close this PDA with? What are your options to close the PDA? Anyone? What would be your option number 1 to close this? The coil, device or surgery? I think surgery in this day and age we can skip. Okay, so device. Now, in a lot of centers now we started only using devices, right? So a lot of you don't know how to put in coil. But this PDA is actually ideally suited for a coil closure because you have a long ampulla, so you can put many loops in. It's quite restrictive, so it's a very good PDA for coil closure. However, being the modern day and age, what if you go and close it with a device, which is quite, what is the smallest device that is available? Okay, so ADO Amplats device, what is the smallest size of the Amplats device that is available? So, yes, you have a 5x4 actually, yes, and a 6x4, right? So, this is either an Amplats device or the Chinese version, Cardiologist, blockade, and so on. What material is this device made of? What is the material? Nitinol, that's right. So that is nickel titanium alloy. Okay. Now, how do you decide on the device size? What measurements do you need to know to decide on the device size? So you need pulmonary end of the duct, that's right. What else? You need 2 measurements to decide. You need the ampulla size, right? You need the narrowest segment and you need the ampulla. Okay, so just for the first year fellows, let me show you that. Oh, I want to go back. I want to freeze it where it starts. So when what size device? Let us say in this case that the narrowest segment measured 2.5 millimeters. So what is the device size? And say the ampulla measured 8 millimeters. What would be the device size that you would choose? Okay. Actually, put it as 6.4, right? Instead of 4.6. Okay, you can put it, but typically it's 6. 6 is at what end? Is it pulmonary artery end or ampullary end? All agree? Right? So when you say 4.6, what is 4? So if this is your PDA here with the narrowest part there, right? The bigger value is going to sit here in your ampulla, right? And your smaller value is going to sit here at the narrowest end. So when you have when your ampulla is, let us start first with the narrowest segment. When your narrowest segment is, let's say, 3 millimeters. Okay, let me say your narrowest segment is 4 millimeters. What size device would you take? Is it the same size? Should the pulmonary artery be the same size? Should it be 1 millimeter more? Should it be 3 millimeters more? So if this here, so you are saying 8.6, okay. So you would take an 8.6. Now in this particular patient, right? In this particular patient, would anyone put an 8.6 in? Let us say the ampulla is 6 mm, but the pulmonary artery end is 4 mm. Would you put an 8.6? Or would you still put a 6.4? I know that's confusing, but this is very important for you to be very clear about. When you have the pulmonary artery end, whatever the size may be, ideally you want a device that is 1 to 2 millimeters higher, right? That is correct. So let us say the pulmonary artery end is 4 mm. Ideally you want a 6 sitting at the pulmonary artery end. But if you take a 6 mm as the pulmonary artery end, your ampulla has to be 8 mm, right? Now let us say in a patient like this, the ampulla is only 6 mm. There is no 6x6 device. So you'll have to put an 8x6 device. What happens if you put a bigger size device and the ampulla is smaller? Are you all understanding this concept? So if the ampulla is 6 mm and you go and put in an 8.6 device, okay, one, you may cause an iatrogenic coarctation because it's not going to fit in, right? So you can cause arch obstruction, yes. Second is, you look at your ampulla like this. If you put the device that's bigger, the device is sitting like this, or it's going to stick in the ampulla and stretch the whole thing. If it can't stretch it, it's going to rupture it. If it can stretch it, it may cause arch obstruction. If it cannot stretch it, it may fit in the aorta, right? So the key of any device sizing with PDA device is that the ampullary ends, you have to measure the ampulla. And your device size cannot be bigger than your ampulla. Okay, because if it's bigger, it's not going to sit, or it's going to sit in the arch and cause a collapse. So if your ampulla in this patient, if I tell you the ampulla is 6, you cannot go bigger than a 6-foot device. Okay. Now, when you look at the narrowest end, if it was 3 mm or 4 mm, yes, ideally you want 1 to 2 millimeters more, but not more than the size of the ampulla. You cannot oversize on that. Is that clear? So if you have, let's say, sometimes you get a tubular duct where this is 4 and this is 5, right? So you can't use an 8.6, you still have to use a 6.4. In fact, in the early days of device closure, at the pulmonary artery end, if it was a 4, we used to use a 6.4. We use the same size, and that's also okay. It's just if you have a very roomy ampulla, you have a lot of place to, to play with, then it's okay. You can oversize by 1 or 2 millimeters. It's not a problem. Okay, all clear on that concept on how to size a device. Now, what is the name of the sheet that is used for deploying this? The same here, we are deploying this device. So you've done an angiogram, then you put your sheet, you push out a little bit in the descending aorta, you come back, you take off the sheet. What is the sheet's name? It's a Mullins sheet that's being used. But remember, there's also a delivery sheet that comes from the company itself, which is the Amplasta sheet. You can use that as well, right? You can also use, yes, you can use the Cook sheet. So any of these sheets. Now, one of the things that we discussed in the last time, when you take it off, right? Here, you're taking it off, right? You're taking it off. You notice by leaving a gap between the end of the sheet and the device, so that you don't have too much, you're not supporting the device and you don't have too much of a stretch on it. And then you're releasing it. In large PDAs, what can you then do through your Mullins sheet? If it is a large PDA, you release the device. Let us say your PA pressure was 90. What can you do through the Mullins? You can do an angio to look for what? An angiogram to look for? What are you doing the angio? If you do the angio to look for what? When you do the angio through the Mullins, you're looking for LPA obstruction. So in a large PDA, you can do an angio through the Mullins and look for LPA obstruction. You can also measure the pressure through the mullins. So instead of just pulling the mullins into right atrium, keep it there in the MPA. Aram se measure the pressure. Make sure that the PA pressure is dropped. Connect it to your angio, do a little angio, make sure your LPA flow is good, then you can go home and sleep well at night. Okay? All clear on that? Now, next question. This is a PDA device. What are the alternative transcatheter treatments for PDA? You mentioned coils. Anything apart from coils? What are the other treatment options for transcatheter closure? So PDA, so coil is correct. And let me ask you, what are the, when we talk about coils, what are the types of coils that are there for PDA closure? Types of coils, vascular plug, yes, that's another thing. Any other items that can be used for closing the PDA? So what are the types of PDA coils? You know, what is the material? The GN type of coil, what is the material they are made of? You know, I'm getting old. Look at this, your answers have to wear my glasses. Okay, that's much better. So they're made of stainless steel, yes, and you can also have platinum coil. That's right. Okay, so one is the coil, the second is vascular plugs, not much used for PDA. Third is the Grifka bag. You all know that, the nylon sack, and you can push the coil in it. The Grifka bag is used for what type of PDAs? What kind of PDAs do you use the Grifka bag? Not used much in India, so a lot of you won't have seen it, but you need to know about it. So what is the Grifka bag used? Which kind of PDA? It's a nylon sack into which you push the coil, and then it sits there. So it's used for tubular PDAs, PDAs that are like this, right? Tubular PDAs. Whereas the device is very good for those which have a good ampulla and then a narrowing. So your conical PDAs. Now, there are others, by the way. You guys have to read. You get a long question on transcatheter methods of closure of the PDA. So you have the knit occlude. You've all heard of the knit occlude device, which also looks like a coil, but you've heard of the knit occlude. So all of you read up all the types of transcatheter closure. Now, what is the advantage that the implant or the blockade, whatever the PDA device has over the coil? What is the advantage? Name two advantages that the device has over the coil. Small sheet is not, my friend. You guys we should do some coils again. The disadvantage of the device is you use a larger sheet. Okay. The coil, in fact, you can deploy through what size sheet? So, yes, it's easy technically, right, to use the device. Less chance of embolization because you have a control, even though in a coil also you can use a control method, but you control, you make sure you're okay, then you release it. Third is better closure. The chance of residual leaks is much less residual leaks with the device. So the reason everyone has moved to the device is easier technique, easier operability, people are just used to it, and better closure. What is the disadvantage? And that comes to Rahul's answer. The disadvantage is, okay, the disadvantage is that, okay, the advantage is you can use it in a large PDA easily compared to coils using multiple coils. The disadvantage is the cost, it's expensive. Second is the sheet size, right? Especially in smaller kids, you still have to use thick French sheets and so on. So in infants, it's an issue. Whereas coils, you can put, what is the sheet size that you use for coil deployment? Okay, this kind of case, easily you could do coil. What is the sheet size? Yes, you can put it through 4 French or a 5 French, right? So it's a very small sheet. So the advantage of the device is that the residual leaks are lower, chance of embolization is lower, ease of operability is high. Disadvantage is these bigger sheets, more expensive. Another, advantage in the beginning is this can be used for bigger ducts, easier in bigger ducts. Okay, all clear on this? MRI compatible. Yeah, after 6 months, honestly, these are all endothelialized, so you can go in an MR machine. And it's in the first 6 months, it's not recommended because you never know with the MR what happens to the device and whether there's any change in it. Okay. Okay, we'll move on to the next. This is again an easy one. You guys do this every day. What is the name of the maneuver? This maneuver, the pushing and the pulling. What is the name? This pushing and pulling. Why is it done? Right. So this is This is the Minnesota wiggle. Right. It was first described in Minnesota. So please remember the Minnesota wiggle. Why is it done? And does everyone do it? And where do you wiggle into? So why is it done? Okay, to look for stability of device, like to make sure that it's not coming into the right atrium, right? Where do you pull the device into? How far down do you go? You go into the IVC? Yes, no. You do it into the right atrium, right? You don't want to pull it into the IVC, and that's why I wanted to show you this angio. You do this routinely, but you just pull gently into the right atrium. You don't, because the IVC is much smaller than the right atrium. So if you're over vigorous, which sometimes early in our career we are, you can pull the whole thing into the IVC and actually cause trauma to the IVC. So it's okay to just pull it into the right atrium. That's enough. Check that it's okay. Some people actually don't do the wiggle because it's not actually physiologic, and if you have flailed rim, sometimes it will slip in. But I think to be on the safer side, you do the wiggle, you're happy with it, then you release it. What is this device made of? Nitinol, all agree, nickel titanium alloy. Okay, quickly, name 4 other ASD devices, and all 4 in a row. Don't give me one by one. Name 4 other ASD devices. Names of 4 other ASD devices. Oh, so tough. Not one by one. I want to see 4 in a row. 4 other ASD devices. So Amplasta is one. Okay, at least name 3 others. Starflex I see here, and Cardiologist. What else? Clamshell, Asdosi. Okay. Life Tech. Angel Wings. What else? Life Tech, Starflex, Cardiologist. So, okay, guys. Now remember that Life Tech is actually a company. So the Life Tech device is nothing but the same device. Yes, now we're talking. Citrus button device, right? So the Life Tech device is nothing but the Amplaster, and it's a Chinese make. So your Life Tech, your Blockade, your Amplaster, these are essentially all this. They're all going to look the same. So now when you talk about CardioSeal and Starflex, Starflex is actually the newer version of the CardioSeal. So since once the Starflex came into play, the CardioSeal is no longer there. So Starflex, Angel Wing device, Citrus button device, not used much, but where there was a button and you button the left atrial side and the right atrial side onto it. So you need to know the other devices that are out there. Now, what is the advantage of Amplaster over, for instance, the Starflex, over the Citrus button? Why is it the Amplaster has become the stable? Okay, so it's self-centering. You all understand what is self-centering? It on its own centers itself to the ASD, right? Unlike in a Starflex device, it has these arms, and those arms you had to kind of center it. So sometimes if you didn't center it quite right, the one arm would be prolapsing into the right atrium, and you have to take the whole thing. So one is this is self-centering. The Amplaster is self-centering. Next advantage. Less chance of aortic wall erosion. Maybe yes, maybe no. There are reports of aortic wall erosion. In fact, any of these devices, there are some reports of aortic wall erosion. Any other advantages over like the Starflex, over the Citrus button? Small size sheet, less breakage. Okay. There used to be a lot of leg fractures of the limbs with the Starflex, so you don't have fracture issues. Fenestrated devices available. One more very important one you guys are all missing. Easy to retrieve. Yes. Retrievability. See, when you talk about devices, a device should be easy to put, easy to remove, right? So if you see in an arm plaster, now you go ahead and release it. Before you release it, for instance, now you put it in, right? You're pushing, you're pulling. You're not happy with it. What do? You just pull it into the sheath. Whereas in the Starflex, there's no option. Once you retrieve, it's retrieved. If you want to take it out, you have to crush the whole thing and pull it out. Here, it's attached. You can do your Minnesota wiggle. When you're happy with it, then you can release it. So the two major advantages of the arm plaster or life tech or blockade, whatever you want to call it, over the rest of the other types of ASD devices: one, easy to deploy; two, easy to retrieve; and the third one was the one that you all said in the beginning, which is it self-centers. Okay, it centers itself. Now the rest of it, little relatively smaller size sheet, that is true. Less chance of residual leaks, therefore less hemolysis, all that is also true. But please remember retrievability, self-centering, easy to deploy. These are the three big advantages. Possible complications very quickly of ASD device. I think you've kind of answered that, right? Okay. Heart block can happen. AV block, yes. Embolization, yes. Aortic valve erosion, air embolism, heart block. Embolization, yes. I would put embolization as number one, right, as your chances of complications. Embolization, you can get air embolism. Hemolysis very rare unless you have a leak, very rare with an arm plaster. But embolization, AV blocks, air embolism, at times aortic valve erosion, yes, mitral valve fractures, those are very rare. But really embolization would be your number one. Okay, let's move on to this. This is a post-op patient. You can see from his sternal wires. What are sternal wires made of, by the way? Not the Narayana guys, because I ask them this every Wednesday. Sinus brady, by the way, in ASD device is quite unusual because you're actually closer to the AV node. So if you're going to have any block, it's going to be more either a heart block or a first degree or a second degree, more an AV block. Okay, so what are these stainless steel? These wires are made of stainless steel. Can you go through a metal detector with these wires? Are you going to ping? Patients will ask you this, can I go through? And the answer is you can go through. They actually don't. Yes, you can go through metal detectors. They actually don't set off the alarm forward. I guess they're very small and not significant enough to. So they're made of stainless steel. So whenever you see these wires and someone shows you an angio and they show you the wires, you know it's a post-op case. The first thing you need to say is this patient is a post-operative patient. Okay, so what is the diagnosis here? Which operation has been done? So it's a post-Glenn. You need to say the whole thing, which is it's a right-sided bidirectional Glenn. Why is it called bidirectional? Because the contrast is going into both the right and the left pulmonary artery. Catheter, multi-purpose. We all agree it's a multi-purpose. View, what view is this? AP view. Okay. So you see here SVC flow coming into the right pulmonary artery into both the flows. What pressures do you need to measure in a Glenn patient? What pressure should be measured? So pulmonary artery. Yes, SVC. You have to say all of this, guys. So RPA, LPA, superior vena cava, and ventricular EDP. Right? So not just PA and SVC, but PA, SVC, EDP, and you can do aortic pressure, but it's not going to make a huge difference to you, right? So you really need to measure SVC and PA. Let us say SVC pressure is 14 and PA pressure is 7. What does that tell you? SVC pressure 14, PA pressure 7. What does that mean? That there is SVC obstruction, right? So that's why the importance of measuring both the SVC pressure as well as the pulmonary artery pressure. So if you have the SVC higher and PA lower, that means there's some obstruction. Okay. Now in this patient, now watch this next angio. You have spill into both the RPA and LPA. Are there any AV fistulae? Oops, it went too fast. So whenever you see a Glen injection, you're going to see whether there's any obstruction SVC into pulmonary artery. You're going to look at the pulmonary Now voice, now it should have come. Yeah, sorry, I was muted. Okay, so we were saying, does this patient have AV fistulae or not? If not, why not? So are there any AV fistulae? Are there any AV fistulae in this patient? Yes, no. Watch that. So there are no AV fistulae, and the reason you say that is because there's no rapid fill, right, of the atria. So when you watch, so anytime you're watching, you're looking for the pulmonary arteries, and then you're looking for the levo phase. Robin, maybe you can mute yourself. So here, and look, 1, 2, 3, 4. It's still, and you haven't filled. And now you're filling the left atrium. So if it's in less than 2 or 3 beats, you fill the LA, then you know you've got AV fistulae. Why do you think this patient has no AV fistulae? Why are there no AV fistulae in this patient with a Glenn? Pulsatile Glenn, normal PA pressure. Any other answers? Why does this antegrade flow? Hepatic factors. So it doesn't really have to do with pressure. Okay, so let's get this very clear, right? So why in a patient with a Glenn like this, right, there are no AV fistulae. The reason there are no arteriovenous fistulae of the lung is because there is hepatic factor that is coming into the pulmonary arteries, and that hepatic factor can only come into the pulmonary arteries if there is some antegrade flow through the right ventricular outflow tract. Right? Is that clean for everyone? So now, if you have no hepatic factor, you have a chance of getting AV fistulae. But it doesn't mean that every patient. Now, if you look here, just did you see that? Just look, Olivia. I need to freeze it there. Look at that MPA. When you inject on the Glenn, you look at the MPA. So this is your LV gram. You see the hypoplastic RV. When you're injecting in the LV gram, did you fill the pulmonary artery or not? How do you tell whether it is pulsatile or not? There are two ways. Now look at this. Just watch here. Okay. This is the what? This is the right pulmonary artery. This one. This is the left pulmonary artery. This is your main. Now watch. Do you see this white stuff here? Okay. That is actually washout of contrast. So when you see washout of contrast, now watch this again. You see that white? When you see washout of contrast, that tells you that there is some forward flow coming. The next way you can tell forward flow is how? When you do your ventriculogram. If in your ventriculogram you fill your pulmonary artery, what does it mean? There has to be forward flow, right? Because this is a Glenn. SVC is going into pulmonary arteries. If the pulmonary artery was disconnected from your ventricle, you're not going to fill. But here you see when you inject in your LV, you're filling up your Glenn. So you know there's forward flow. In a patient who has even a drop of antegrade flow, they will not develop AV fistulae because the hepatic factor is reaching the lungs. Now, when some of you answered pressure, when you talk about high pressure in a Glenn, that can lead to opening up of what? What opens up if you have high pressure inside the Glenn? Veno-venous, that is right. So get the difference between AV fistulae and veno-venous collaterals, right? AV fistulae in the setting of a Glenn are fistulae that are going from the pulmonary artery to the pulmonary vein and back into the left atrium. In a situation of the AV fistulae, patient will be blue because the blood that goes into pulmonary artery is not getting oxygenated by the capillaries. Instead, you see here now, pulmonary artery, okay, going, pulmonary artery, capillary, now coming into left atrium through pulmonary vein. So there is enough time for the blood to get oxygenated. If you have a direct connection between pulmonary artery and pulmonary vein, you don't go through the capillaries, you don't get oxygenated, those babies can be very blue, but you would have rapid washout. So when we talk about AV fistulae in Glenn, we are talking about pulmonary AV fistulae. Veno-venous collateral, on the other hand, would be if something opened up from the SVC and filled the IVC system. And that would be seen when you have high pressure. So when it's a low pressure system, it's unlikely to get veno-venous collateral, but it does not affect the formation of AV fistulae. In fact, let me ask you this question. When you have AV fistulae, what pressure do you expect in the pulmonary artery system? 5 of 20. You get actually a very low pressure, that's right. Because when it's an AV fistulae, the blood very quickly goes into the pulmonary vein and into the LA. So you actually have the whole resistance is very low. So it's like when you have a systemic AV fistulae, right? Your lower distal pulmonary, your systemic resistance is low. Similarly, here your resistance becomes very low. So when you have inject in your gland, you're looking for AV fistulae, rapid fill into LA, and you're looking for veno-venous collaterals, especially if your gland pressure is on the higher side. Even if it's not on the higher side, you're looking at. Very quickly, importance of IVC injection and where do you inject in the inferior vena cava in a patient. So you're looking for duplication, you're looking for interruption, right? For Fontan completion, you're looking for drainage, and where should you inject? Was this injection correct for the IVC? Yes, so you're looking for hepatic venous, you're looking for duplication and interruption. Yes, and you should ideally do it down here. You see this injection, a lot of people just inject, put the Berman somewhere in the middle and do it. But if you're looking in for a pre-Fontan, you need to do it down here and follow it all the way up, because you have to make sure there's no duplication or interruption. Let us say the IVC is interrupted. Then you go and do a Fontan. What is that operation called? Right? That's a Kawashima. So if your IVC is interrupted,